Hello again, and welcome to Miami Community News. I'm Dr. Anthony Gonzalez, and welcome to a Miami Community Health Show. Once again, we have another important health topic for you today. Today, we're here with our orthopedic surgeon, Dr. Chris Hodgkins. We're here going to talk about a specific orthopedic problems, one part of our body that many of us, I personally have had some of these issues in my life as well. We're going to talk about the foot and the ankle. It holds us up, it moves us along, it gets us through our day, but the foot and the ankle and the lower part of our legs are very important for us. So we brought Dr. Hodgkins here to talk with us today, and I want to welcome Chris over to us.
Thanks, Tony. Appreciate you inviting me. Great to be here.
All right. Well, welcome. Thanks for having us, and tell us a little bit about yourself. Tell us where you're from and what you're doing.
So originally from England, Liverpool, England, which is in the north of England, and went to medical school in England and had a bunch of injuries growing up playing rugby, and decided that spent most of my life in an orthopedic surgeon's office, really respected those surgeons and loved what they did, and decided that I would like to do the same thing. So I went to medical school in England and then came over to the US and trained over here as an orthopedic surgeon. And now I'm practicing at the Miami Orthopedics and Sports Medicine Institute, where we have a great group of orthopedic surgeons.
Wow. Yeah. And so you did a little bit more specialization. I mean, we see orthopedic surgeons that people break their hips and they fall, or broken bones, and even orthopedic surgeons that do back surgery. You did some more specialization, right?
Yeah, so sure. I really had a passion for foot and ankle surgery. And so I went to do a fellowship at the Tampa General Hospital for a year, subspecializing in foot and ankle trauma. And actually, before I started my residency, I did a year of foot and ankle research up at the Hospital for Special Surgery in New York. So I had a real passion for that. My fellowships developed that passion, and now that's essentially pretty much all I do.
Yeah. So you're only taking care of people that are doing foot and ankle problems, broken bones in the arms and the legs and broken pelvises. That's somebody else.
Correct. I mean, I still take calls, so I can take care of that stuff and still do a little bit, mostly foot and ankle.
All righty. And so what about foot and ankle surgery is so special? What has really progressed in the last, let's say, 10 or 20 years in that area of the world?
Well, so much. I mean, as you mentioned earlier, fractures and injuries to the foot and ankle are so common, particularly in sports. And nowadays, the old-fashioned way to do things was make big incisions and put lots of metal in and do things in a maximally invasive fashion. And we're trying to move things along, particularly in our group. We have the sports expertise and we have our trauma expertise, and we're trying to combine the two to actually treat these injuries better so that patients have better outcomes and better experiences. So we're actually taking a minimally invasive approach to these injuries. So we're trying to fix them through smaller incisions. Smaller incisions mean better cosmesis for the patient. The ankle looks prettier. The smaller incisions lead to less pain after surgery, less swelling. They consume less narcotics. It's just a win-win all around.
All righty. And so you guys take care of the weekend warriors and the business people and the bank people, but you guys take care of athletes as well, right? You guys take care of athletes from all the teams in South Florida and beyond, right?
Correct. We have some great surgeons in our group, and we're supported by Baptist Health South Florida, which provide us with great facilities and great teams to look after these professional sports outfits. So our group as a whole, we look after the Miami Dolphins, which is really exciting. We look after the Florida Panthers hockey team, the Miami Heat with Dr. Selznick. And then we look after the FIU athletic department. We take care of the Miami Open tennis tournament. We used to take care of the golf. Unfortunately, it's not in Miami anymore, but that was a lot of fun personally for me as well. And then Baptist Health help us sponsor the outreach program to provide physicals and game coverage for Miami-Dade public schools. And Baptists do that out of the goodness of their heart, and they provide it as an outreach program. And we're really proud of that at Miami Orthopedic and Sports Medicine, and proud of Baptist allowing us to do that. So it allows us to make sure that our high school athletes are getting the most appropriate orthopedic treatment. It takes a lot of time and a lot of expense, but Dr. Uribe, Dr. Heckman, Dr. Vijak started that many years ago, decades ago, but we've carried on that tradition.
Oh, that's awesome. That's awesome. All right. So let's get into a little bit of what the common problems that will be seen in your practice. And I think I want to preface it by saying that, there are a lot of people that have injuries that don't require surgery. They may not need to see the surgeon,
Correct.
But you have a lot of professionals in your practice that know what they're doing, that can deal with all these non-surgical problems. So Let's start off with Achilles rupture. And, Achilles rupture is, I guess, common because there have been some famous athletes that have had Achilles ruptures. Kevin Durant, didn't he have? He had it. Some football players. I mean, I can remember. You probably will tell us who's had an Achilles rupture, maybe. And what is an Achilles rupture? What is the Achilles tendon?
Yeah. Well, thanks for prefacing that. As you said, I am a surgeon, but our group will look after anything and everything. So if you've got a foot and ankle problem, we'll find someone to take care of it. But Achilles ruptures, Achilles is the largest tendon in the body, and it's put under a lot of stress. And Achilles ruptures is when the actual Achilles just snaps. And it can happen to anybody. It happens to professional athletes. As you say, these guys are the most well-conditioned athletes out there, but it still happens to them. So it happens to them. It happens to weekend warriors. And when the Achilles tendon snaps, it doesn't necessarily need surgery. Traditionally, again, it used to be fixed through a big incision. Those big incisions used to get infected, and then they would become disasters. And so nowadays, we developed a technique to fix it through a 3-4 centimeter incision, minimally invasive pause, Achilles repairs. And so the majority of them now, actually, we recommend surgery for, whether you're 16 years old or whether you're 60 years old, because the literature is borne out that they actually do better with surgical repair. But it's a bad injury, whether you fix it surgically or whether you don't, and we'll always give you both options. We'll give you the pros and cons of both. The problem is that it doesn't matter whether you fix it or not. It doesn't matter whether you're an athlete or not. It takes a whole year to get over that surgery. And most of the time, you're never quite the same. As you see in these pro athletes, they never quite come back the same.
Wow. Okay. And so for people to understand the Achilles tendon, tell them where it is in the body and what it does.
Yeah, Tony, sorry. So it's at the back of the leg. It attaches the just above the knee and just below the knee to the calcaneus bone, which is in the heel. And it allows us to push our foot down, which gives us that push off and that acceleration. So basic walking involves Achilles tendon. Obviously, explosive motion involves the Achilles tendon. And when you rupture it, you lose. You've still got some because you've got other tendons that help, but that's the main plantar flexor of the foot, the main one that pushes it down. So when you lose that, it becomes quite disabling.
All right. And then it can occur from just anything, walking, or it has to be with sports or a vigorous activity?
Yeah, it's normally an explosive type action. So landing on the foot or pushing off suddenly, very unusual for it to occur with just walking, but it can just a trip and you stop yourself with the foot and you get that sudden eccentric motion, and that's how it happens. So, but I'm glad you bring this up, because unfortunately we see a lot of Achilles tendon ruptures that are misdiagnosed as ankle sprains. So if you think you have an Achilles rupture, or think you have an ankle sprain, you have pain and swelling that just doesn't go away, it's best to get it checked out.
Yeah, I was just going to ask you. I mean, I think, do you know if you have an Achilles rupture? Is it so bad that you know it, or what are the first things that patients are going to feel, or when should they seek care?
Pain and swelling. So anyone who has an injury and has pain and swelling, foot or ankle, needs to seek care. Go to an urgent care to begin with, get a basic X-ray. And then based upon that, they'll give you an indication about whether you need to follow up with Orthopedic Surgeon or our group. And again, we're always happy to see patients to exclude the possibility of that. And we have plenty of extenders and practitioners that are happy to see patients. But in answer to your question specifically, some patients don't know they have an Achilles tendon rupture. Most do have some degree of pain and swelling, but you can actually walk with an Achilles tendon rupture. And that's what a lot of these patients say who have missed injuries. But I could walk. I didn't realize I had it. But you can walk. Wow. So there's a spectrum of symptoms that patients have. So always best to get it checked out.
All right. So I guess the take-home message is that Achilles rupture is obviously a bad injury, requires surgery most of the time, long recovery. But it could be underestimated that you could have an Achilles rupture and not even know it. So any pain or swelling in the ankle, seek some medical care, and then we'll decide whether you need to see a specialist team like your team, or God forbid, see you and have to have surgery.
Exactly.
All right.
Yeah.
All right. So that's with the Achilles. Now, ankle instability, I don't even really know what ankle instability is. I understand, I guess your ankle is not stable, but explain to me and explain to our viewers, what is this other common diagnosis that you see in your practice?
Yeah, glad you bring that up as well. One of the most common things I see. Why? Because ankle sprains are one of the most common injuries. I'm sure you sprained your ankle, right?
Yeah.
I've sprained mine 100 times. Everyone who does sports will sprain their ankle. Now, most of them will heal perfectly. However, there are a small percentage that the ligaments will heal, but they'll be loose. So ankle instability means when you feel like your ankle is loose, you don't feel secure on it. You don't feel like you can cut, jump, and land on it, because you feel like it's going to give out. And sometimes it will give out. So a history of that, or frequent sprains, or just pain and swelling in the ankle that just won't go away. It just doesn't feel right after a sprain. Most likely that's ankle instability, which means it's just sliding around too much. And there's a protocol of treatment. Doesn't always need surgery. That can be treated with physical therapy and a brace. You can actually train some stability back in the ankle. However, if it does, again, that's a big surgery that takes a while to get back from. So that's what ankle instability is. Many people don't know the definition, but again, if you got any of those symptoms and it's just not, your ankle's just not right, I'll bet you've got a degree of instability. Come get it checked out. Let's take a look.
So a little bit for understanding. So that means that the ligaments are loose. And
Correct.
if you brace them and they go through therapy and everything tightens up, then great, they don't need any surgery. If they need surgery, what happens in that surgical procedure?
So it's an hour procedure. It's quick and easy for me. It's just not quick and easy for you. But I put a camera in the joint. We do an ankle arthroscopy through mini incisions. Just make sure the joint looks good, the cartilage looks good, because you can often get injuries in the joints as a result of the instability. And then we make a mini incision on the ankle, and we actually cut the loose ligaments off the bone. And we put some special plastic screws in and then tighten the ligaments back down to the bone. We're now also using a special device called internal brace, which many people may have heard about, which is kind of a seat belt. So we're putting a screw in both bones where the ligament traverses, and it's an extra coat over the ligament that acts as a safety belt for the ligament repair, which now allows me to let you walk day one after your ligament surgery, let you move your ankle day one after your ligament surgery. So it's allowing us to accelerate rehab. So we started in our athletes, but now I do it for all my patients.
Wow.
It's been a game changer. It's called internal brace.
Wow. So actually, I was going to ask if your athletes can get back after one of these injuries, because it sounds like a big injury, but it's obvious that they are getting back to.
Oh, yeah.
They're getting back to
very quickly.
Wow.
Yeah.
Okay, so we've talked about Achilles rupture, we've talked about ankle instability, and last but not least, bunions.
Yeah.
We see that commonly. Sometimes we see it because of the fact that it causes pain, it causes deformity, it causes obviously cosmetic issues. So for those that don't know what a bunion is, explain to them. And for those that know what a bunion is, like me, what is actually popping out of the person's foot? You know,
so a bunion is the bump on the inside of your big toe. So it's the big toe drifting over, and then it's the bump that also creates. And you know, I see it all the time, and it's a terrible problem. It particularly affects ladies because they want to wear nice narrow shoes. It's largely a genetic problem, contributes to a little bit by shoe wear, but unfortunately, most people are programmed to have that problem. And so it sticks out, it rubs on the shoe. Patients normally complain that they can't wear shoes. They can't wear even basic going out sneakers during the day. They can't exercise. They can't wear the fancy shoes at night. And the toes cause problems because they rub on each other. So it needs to be checked out. There's lots of different treatment options. The basic stuff starts with wearing wider shoes. You can pad it, you can tape it. Unfortunately, there's nothing that's going to cure it apart from surgery. So there's two options. One is you manage it with the shoe wear modification, the taping, the spacing, etc. And the second is surgery. Thankfully, there's 100 different surgeries out there for bunions, Tony. The reason there's 100 is because none of them really work.
Yeah, I know that.
and it's just that I never used to like treating bunions because it doesn't matter how good of a job I do. I can do a perfectly technical job, but sometimes it just doesn't turn out well. But again, on this minimally invasive theme, we have a new surgery where we're making tiny incisions. We're cutting the bone because we have to cut the bone. Cut the head, move it over, reposition things, and then you have to let that bone heal. But we're doing it through mini incisions now, and it's been a complete game changer. Quicker surgery, smaller incisions, less pain, less swelling, faster return to walking, faster return to exercise, work, and play, and driving. And, you know, it still takes a good 4 to 6 months to get over a bunion surgery, but it's so much better nowadays. But the decision whether to have surgery or not is a tricky one. So again, something we need to discuss.
Wow. Okay. And not everybody needs surgery, right?
Correct.
No. Yeah. As long as it's causing either a physical disability or a cosmetic disability.
Correct.
Right.
My 4 criteria are pain that's interfering with quality of life on a daily basis. If the deformity is stopping you from wearing certain shoes, which is interfering with activity, which is affecting your quality of life. If it's affecting your shoe wear, which is a lesser reason, but still a reason. And then the last reason is the cosmesis. We don't like doing it just because you don't like the way it looks. Just because, as you know, Tony, there are so many complications with surgery that you can't control. They don't happen very often. But if they do, most of those patients regret doing it because if they're only doing it for cosmetic reasons, they regret.
Yeah, there's got to be more of a reason to do it.
Correct.
All right. So we've talked about some of the common conditions, and you know what? I want to spend the remaining time talking about, you know, how to deal. You know, I have had medical experts in these seats that talk about conditions that, you know, we see 10,000 of them a year in the U.S., very small volumes with the 300 million people that occur in the U.S. But foot and ankle problems are very common. and you guys and your team, you see a lot of patients. So how have you been able to manage patient experience and someone who wants to come in and see, I want to see the surgeon, but you don't necessarily need to see the surgeon and you don't want to see the surgeon. Listen, I'm a surgeon. I have people who say to me, listen, I'm coming to see you. I really don't want to see you, but I need surgery, you know? So how do you deal with the patient experience in a busy, large practice like you have?
That's a great point. I'm glad you bring that up. You're right. A lot of people do want to see the surgeon, and I would love to be able to see everybody, Tony. Even if you don't have a surgical problem, I'd love to be able to see you. Unfortunately, we can't, because that doesn't allow that then stops us from seeing the people who do need surgery. So we've created a tier of healthcare practitioners so that we can screen everybody, so that we can see everybody that needs help. But it's often our physician assistants or our nurse practitioners who are very well trained by us, so they know exactly what they're doing, and they will do the basics. They will examine the patient, order advanced imaging if necessary, decide or diagnose exactly what the problem is, and then they'll triage them appropriately. If that person needs to be a surgeon, then you'll get in to see the surgeon immediately. If they don't need to see a surgeon, then they can be treated with the basics. Then they'll do that. They'll execute the physical therapy. They'll put them in a brace. They'll do this, and they'll follow them. And if eventually they might develop something surgical, then fine, we'll plug them into the surgeon. But that's what we've done. We've created this tier of medical practitioners with the surgeons as the end point. Because as you say, if you don't need to see a surgeon, you don't want to be there. Most people don't want surgery, and we don't want patients to have surgery either. We have to keep ourselves available to see the things that really do need surgery. And so that's how we've solved that problem.
Now, you guys educate your patients quite a bit, and I have one of my supervisors in my office actually went to see your team and shared with me the instruction book and the playbook that you guys use.
Yeah.
So let's talk about that. How has that been useful in your practice?
Well, thanks for bringing that up. This is a real passion of mine, as I know it is of yours. And I've actually borrowed some of your techniques as well. You know, I really look up to you because I think we both share this passion for improving patient experiences. Two of my goals: improve outcomes, which we're trying to do, and improve patient experiences. I've been a patient myself, and I have very high standards, and I'm disappointed most of the time by the experience in my own health system sometimes. So I'm trying to improve every step of the patient experience so that we can make it as good as it can be. Now, we can never be perfect. You know that. As hard as we try, we can't please everybody. We cannot be perfect, but I'm always trying. And I think that's the most important thing. I think information and education is one of the most important things, and communication is one of the most important things patients want. They want to know what's going on with the logistics of the office visit. They want to know what's going on with their diagnosis. And most importantly, they want to be able to communicate with their medical team beforehand, during the visit, and after the visit. And you'd be amazed how many groups you can go to where you leave and you're like, okay, I had a question. Well, I don't know who to answer. I don't know who to call. Then they find a number, they call, they can't get through to who they need to get through to. These are really simple things. It shouldn't be happening like that. Now, you know, as medical practitioners, we're so busy that we don't get time to devote to improving the efficiency of our practice. But myself and my team have really focused on that, as you have, to say, okay, how do we make this better? So as you mentioned, the playbook. I give my patients a 30-page booklet when they arrive. Now, some of them throw it. I don't want to read that. And that's fine. If you don't read it, don't read it. But the people who want the information, it's there. And it explains everything. It explains who they're going to see, what the name of the x-ray tech is, what the name of the DME, what DME is, all that stuff. I want patients to know who they're seeing, who's touching them, who's involved in their medical care, and then what happens during the visit, and then what happens after the visit. And I have a communication protocol which says, if you have a problem, this is the person to call, this is their telephone number, this is their email, so that we don't lose contact with them.
Yeah, that's very important because especially, you know, I came from a practice where we were 3 guys with 10 employees in one office. Now we're 15 guys and girls, and we have 6 offices,
Right.
one single phone number. And a patient would call to speak to Dr. Anthony Gonzalez or give a message to Dr. Anthony Gonzalez. It could be picked up in the keys and nobody knows. So yeah, communication is a big deal, especially that we're both, you know, we're working with Baptist Health. And of course, that's very, very important. And so, of course, the patient experience. And I always give an example of up the road in Orlando, a good buddy of mine who's a urologist, and he will see 100 patients a day in his team. And I've heard from patients. I have not been a patient up there, but I've heard from patients, friends, that the experience is phenomenal in that regard. So definitely something that we and all physicians need to improve on. So what do you see for the future of foot and ankle surgery, or foot and ankle diseases or conditions?
Yeah, well, I think the future is really exciting. I think there's a couple of themes. I think that everything we do is going to be done better. more minimally invasively through smaller incisions, which is going to lead to quicker recoveries and better outcomes for patients. And that's our main goal. I think the biologics are going to play a huge role. And by biologics, I mean PRP, platelet-rich plasma, where we take your own blood and inject it for certain conditions, so that maybe your Achilles tendonitis might not need surgery because we can make it better with this. There's all kinds of adjunctive biologic injections, which I think are going to be a complete game changer and keep patients out of the operating room, which is ultimately the goal, our goal for everybody. We don't want to operate on these patients. So minimally invasive, the use of biologics, and then as we've already talked about, I think we're really going to change the experience for the patients.
Wow. No, I've learned quite a bit. I mean, I've learned about the three conditions that we've talked about, which is Achilles rupture, the ankle instability, and the bunion. But I've also learned that you may not need surgery, and a great team and creating a great team is very, very important.
Yeah.
So, obviously, I think this has been great information for our patients. First of all, to get to know where they should go if they have a foot and ankle problem. And number two, learn a little bit about the medical issues or the orthopedic conditions that they're commonly had. Any parting thoughts or any words of wisdom for our guests before we adjourn?
Yeah, absolutely. Words of wisdom are, if you have a foot and ankle problem, please reach out to us. You might not need to see me, but you probably need to see one of our team. Take care of your feet, take care of your ankles. As you say, they keep you up, they keep us going. They're very important to us. So reach out. We can take care of whatever problem you have.
So before we go, taking care. We didn't talk about taking care of your feet. And I've heard so much about, let's say, I know, like probably obesity is not good for your feet,
Correct.
Right? How do we take care of our feet?
Well, particularly pertinent in South Florida, everyone's walking around in flip-flops, sandals, or barefoot. One of the worst things you can do. So stay healthy, stay light, stay fit, appropriate shoe wear. Barefoot walking, flip-flops, terrible. High heels, okay. It's for certain times for going out and looking pretty, but not all day, every day, because you'll regret it at some point. So it's important.
And do we still tell our elderly patients, I guess the diabetics, to look under their feet as well and inspect your feet?
Oh, absolutely. Diabetes is a completely different conversation. But yeah, don't walk barefoot, because diabetics don't know if they're walking on a hot surface, cold surface, walking on a pin. They've got a cut on the bottom of the foot. So absolutely, they need to look at the feet twice a day minimum. They need to get some podiatric help, cutting the nails, taking care of basic foot care. Very, very good, great point there, Tom.
All right. So we learned, get rid of the flip-flops and limit the high heels in South Florida. That's difficult. Women, they love the flip-flops and the high heels. So.
Yeah.
Well, great conversation. Well, I want to thank Chris for being with us here today. I want to thank everybody for watching. And remember, if you have swelling and pain in your ankle, first, you have to go see Chris and his team at Miami Sports and Sports Institute there at Baptist Health. And of course, remember to take care of your feet. Clean them, wash them, make sure that you keep your weight down, exercise, eat right, like we've always heard on this show. And of course, inspect your feet to make sure everything's okay. So once again, on behalf of Dr. Hodgkins, Dr. Anthony Gonzalez here, Miami Community Health, signing off, and we'll see you next time.